And recently she defended her PhD on willingness to pay for reducing health risks. And today she will be talking to us about a recent project developed by IHG in a partnership with the University of Southern California about the quality of life in the Swedish population during the COVID-19 pandemic. So, Sarah?
Yeah.
All yours.
Thank you. Thank you for inviting me to this event. As mentioned, I will present a study which we have performed in collaboration with researchers at the University of Southern California. And if you're interested in the details, you can download the full report on our website. And I'm going to start presenting a graph that you may all be very familiar with by now. This graph shows the number of new cases of COVID-19 in intensive care between March and November this year. And as you all know, we had an outbreak of the pandemic in March. And then we had the peak of the first wave in around April. And since the end of October, we have seen a beginning of a rise in cases again. And we are now in what some would refer to as the second wave. And this pandemic has initiated numerous various of strategies to try to mitigate and suppress the pandemic. These strategies are also referred to as non-pharmaceutical interventions, or NPIs. And Sweden has been known for applying a bit less restrictive approach compared to other countries. We have not applied a full lockdown. However, we have still had experience of several restrictions and limitations, as you all know. We have a limited number of peoples that can gather together. So we have restrictions in restaurants, cinemas, etc., which has had a big impact in those industries. And for a while, we had a ban on visiting nursing facilities, and that's going back now during the second wave. And we have also had travel limitations, we're working remote and so forth. And all of these changes had economic and social consequences. We have seen a big drop in GDP, we have rising unemployment. And as for the social consequences, you may all have experienced changes to life. You can no longer do all of the things that you did before the pandemic, perhaps. You cannot travel as you did before or meet friends at places where you did before and so forth. And all of these consequences are factors that we know will have an impact on the quality of life. So the objective of this study was to estimate how COVID-19 has impacted the quality of life in the Swedish adult population. And in health economics, we often measure quality of life on a scale from 0 to 1. And to find a point estimate on this scale, we can use different approaches. One approach is to use the visual analog scale, the VAS scale, which is simply presenting a scale from 0 to 100, where 0 represents the worst health you can imagine, and 100 the best health you can imagine. And then you just place a cross where you find yourself today. Another approach to find the point estimate for the quality of life is to use EQ5D, which is a well-known instrument for measuring quality of life within health economics. It consists of 5 dimensions, so you basically just respond to your ability or your level of problems in 5 dimensions, which is mobility, self-care, your ability to wash and dress yourself, your ability to perform usual activities, your level of pain or discomfort, and your feeling of anxiety and depression. And each of these dimensions have 5 response alternatives. You can have no problems, slight problems, moderate problems, severe problems, or extreme problems. So when you have responded to this questionnaire, you have given us a health state, what we call a health state. For example, if you have slight problems in all of these dimensions, that is what we refer to as a health state. And then we can apply a quality of life weight to that health state by using a previously performed study, what I will refer to as a background study. And in that background study, there has been questions going out to the general population where they have been asked to rate those health states by using the method time trade-off. So, for example, if we take that health state having slight problems in all dimensions, you go out to the general population, present that health state and say, okay, assume that you live for 10 years with this health state. For 10 years, and then you die. And assume that you could also live in full health, no problems in any of these dimensions for 8 years, and then die. Which one would you choose? So time trade-off is basically trading your lifetime for quality of life. So the EQ5D is indirectly based on a trade-off. And that's why we sometimes consider this to be a more valid approach, because you require some kind of hypothetical trade-off. Looking at the VAS scale, that's not requiring any kind of trade-off. You're simply putting a cross wherever you like. And it doesn't require you to think about what you sacrifice. So that's why the EQ5D is sometimes regarded as more valid than a VAS scale. However, the VAS scale allows you to include all factors that can have an impact on your quality of life, while the EQ5D is more restricted to those predefined dimensions. So in that way, some think VAS is more responsive to quality of life changes. So there are pros and cons with each of these approaches that are important to keep in mind. In our study, we sent out web surveys to samples of the adult general population. We identified those in internet panels. And the first survey was sent out in February before the pandemic outbreak. And the second survey was sent out in April during the height of the pandemic in Sweden. And in the first survey, we used VAS scale only to measure quality of life. And in the second survey, we used both VAS and the EQ5D. And to calculate the quality of life using the EQ5D, we used a so-called background study from the UK, which is called Devlin et al. You can find it online. And also, we didn't have a baseline estimate for the EQ5D because it wasn't included in the February survey. So instead, we used the latest Swedish measurement, which was performed in 2017 and published in Burström et al. 2020, which you can also find online. And the result from this study showed that we found a reduction in quality of life in the Swedish general population using both approaches. What you see here in the blue bars is the quality of life before COVID-19. So that's kind of the baseline estimates. And as you see, it's not at 1, because even before COVID, of course, people had other health problems that impact their health. You can also see that the quality of life in the baseline estimate is higher for the EQ5D, and that's probably due to that trade-off method, as I explained before. The orange bars shows quality of life during the height of the COVID-19 pandemic, during the first wave in April this year. And as you can see, the quality of life is reduced somewhat using both approaches. Since we had access to individual-based data in the VAS measurements, we could control for background characteristics because this is a cross-sectional study, so we compared different samples. So but we could control for at least gender, number of household members, education, employment, and income. And while controlling for those factors, we still had an impact of time of the April measurements. And there was a reduction in quality of life of 0.07 using the VAS measurement, and that was also highly significant. For the EQ5D, we only had access to sample data, so we couldn't use controls. So that's a bit more uncertain comparison. However, it was a smaller reduction compared to the VAS measurement. This could be because of the trade-off method, but it could also be that EQ5D cannot capture some changes in quality of life that the VAS is able to capture. So we don't really know which measure shows the most reliable estimate here. If we go forward and look at how the VAS measurement is by age, when we stratified it by age, we see that there was a larger reduction in quality of life among respondents in the working age population. That means those who are below 65 years old. And if you look at those who are above 65 years or older, they actually have non-significant changes in their quality of life. So it seems like quality of life hasn't changed in those age groups. And that's maybe a bit surprising because we all know by now that those who have been most severely impacted by COVID-19 are the older groups, age groups. And at least in the springtime, they were also very much impacted by the restrictions. Some were very isolated because they were at the highest risk and they were asked to keep their contacts with other individuals, other people very restricted. So we would perhaps expect a reduction in these age groups, but we see the opposite, that there is a reduction in the younger age groups. And the explanation for this is not, we cannot really find a certain explanation, but we have a hypothesis based on a question that we included in the April survey. We asked them about how worried they were about COVID-19 with respect to the economic situation for the foreseeable future and with respect to their own health. And here we saw that the worry about the economy was higher in the age groups below 65 years. And the opposite was true for the worry about your own health, which is kind of a logic that when you're older, you're more worried about your health, since that the risk increases with age. We also saw that worry about the economy had a larger impact on the quality of life during the pandemic than the worry about health. So an hypothesis is that the reduction in quality of life is to some or to a large part impacted by the worry about the economy. Another finding that supports this hypothesis is that we had a larger reduction among respondents with a less certain position on the job market. When we stratify the VAS results by occupation, we see that the unemployed students are those who have suffered the largest loss in quality of life. So that supports this hypothesis. But we also know that it might not be the only explanation. It most likely isn't. We saw before that whereabout health has an impact, so that's also part of the explanation. We have also found that households with only one adult has suffered a larger loss in quality of life than households with 2 or more adults. So loneliness and the social part is also part of the reason why we have a reduction in quality of life. And then the question is, how large is this loss in quality of life, and what does it imply? We have also done another study, which you can also find on our website, where we have estimated the loss in health due to excess mortality during the first half year of this year. So we expect that to reflect the COVID-19 deaths, basically, from January to June this year. And if you look at this graph, the blue bars represent the QALYs lost due to excess mortality during the first half year of 2020. So QALY is quality adjusted life years. So what this is basically that we take the life years lost due to the excess mortality and weight that by the quality of life during those remaining life years. And then we get the QALY loss due to excess mortality. And as expected, we see that most QALYs are lost by those who are 60 years or older. And that's because the COVID-19 deaths mostly appear in the older age groups. So looking at the orange bars, this reflects the results I have presented so far. This is basically the quality of life loss in the general population. So here we basically assume that the point estimate reduction that I have described is extrapolated to the entire April. So this is only the loss for the April month. And that has been then calculated as 1 month duration with the quality of life reduction that I presented before, and then scaled up for the entire population in each age group. And as you see, there are no orange bars for 70 years or older. That is because the quality of life loss was not significant for these age groups. And the finding is that these, summarizing the orange and the blue bars, you can see that they are in the same sizes, roughly. And we shouldn't directly compare these and draw any conclusions out of that. The only thing we can say is that we see that the loss of quality of life in the general population is large and significant. And this supports using a wider public health perspective to keep in mind that mitigation and suppression strategies have a big impact on the population quality of life. You can also ask how our estimate compared to previous estimates. And one way to check for that is to compare our baseline estimate, our measurement in February, to previous measurements using VAS in Sweden. In this graph, our baseline estimate is shown in the orange bars. And those bars that are shown to the left of that is previous measurements in Sweden using the same approach, the VAS scale. And what you can see here is that for the younger age groups, between 18 and 44 years old, you see a tendency for a reduction in quality of life over time. And this could reflect a real change. It seems like it is because the reduction is quite consistent from different studies, but it could also, of course, depend on the way data has been collected. For the older age groups, for those 65 years or older, we instead see the opposite. We see that our measurement is higher than previous measurements. So this could also again reflect a real change. Perhaps they have higher quality of life today than before, but it could also depend on how we have collected data. We used an internet panel to identify respondents, and perhaps we were not able to reach those who perhaps are older and less healthy. That's just an hypothesis, we don't really know. So, but these changes in quality of life over time is interesting in themselves and may be subject for future studies to find out. Other possible future studies that would be interesting to see is follow-up measurements in Sweden on the quality of life during the pandemic, because as I've explained before, we measured at the peak of the first wave in April. And that was a very specific situation. We were in the beginning of the outbreak. There was a lot of uncertainty about how long this would go on for and so forth. So that might not apply for the situation today, for example. Today we know that there is a vaccine coming, so that might impact expectations very much, and the quality of life could be impacted. At the same time, we are at a phase where we see a lot of new restrictions on our daily lives that could also have an impact on our quality of life. So the measurement in April might not apply throughout the pandemic. So it would be interesting to see how is the quality of life today. When we did the study in Sweden, a similar survey went out to the population in Norway and the US. So we could also compare our results to Norway and the US. With respect to Norway, it could be very interesting to see how our countries compare, because we have similar countries, but we apply different approaches to the COVID situation. Norway basically applied a lockdown, and while Sweden were very less restrictive in its approach to the pandemic. And you can see in this graph the number of intensive care patients over time for Norway and Sweden, where you see that Norway have much less cases. On the other hand, they have been much more restricted in their daily life than we have been in Sweden. In the US, there is a publication of their results that came out a month ago, and you can also find that online. Looking at the published results, we can see that they have found the same thing that we did in Sweden, that those who were most affected in their quality of life was the youngest respondents. So it seems like they have a similar impact. And that was all for my presentation. Thank you.
Thank you so much. If you have any questions, then just put them in the chat and I will ask them later. We have quite a bit of time, so anything you want to ask, you can go ahead and do it. I guess we can start off with a question from Isbor about what kind of plans for follow-ups you have and what you think the appropriate timescale for those would be.
Well, it sort of depends on our resources. We have been thinking about the new measurements, but so far we haven't had the resources to do it. So as soon as we have that, we will perform new measurements. And I suspect that it would be very interesting to do a new measurement by now, because now we are approaching a new peak. So it would be interesting to see how the quality of life is currently. But unfortunately, we are not at the point where we have the resources for it.
Do you think that's because the research funding is focused more on the what should we do and how can we cure this and that kind of thing, rather than on this kind of investigation?
Yeah, most likely. These kind of questions often come later on, but then it's also too late to do the measurements. So that's the situation we have to accept, perhaps.
We have a few questions in the chat. So do you think the large degree of non-response bias impacted the results, and was the non-response larger amongst elderly populations?
Can you take that again?
Do you think the large degree of non-response bias impacted the results, and was the non-response larger in elderly populations?
Okay. Well, the response rate is quite low. On the other hand, it is similar to many of these kind of studies, at least online. We know that we cannot expect higher response rate. We haven't looked a lot on the non-responders, and we usually don't have a larger non-response among the older. Often it's actually opposite, that they are more, have a higher response rate in the older subgroups. But we also know that the older subgroups usually is not as representative as the younger age groups, because we have the internet use is lower among the older age group in general. So agreeing to participate in an internet panel, the tendency is not as large for the older subgroups. So.
And the second question in the chat is whether you investigated an association between occupation types and quality of life, which was actually answered in the thing, but maybe you can go back to that slide for this person who made that part of the question of the presentation.
Yeah, exactly. So here is the stratified result by the VAS by occupation.
If you have any follow-up question to that, then let us know, and then we'll continue on that track. So you mentioned that the study looked at comparisons with US and Norway, but are you aware of other studies, maybe with slightly different designs, and if their kind of results track with yours, or if you think there's something very particular about the Swedish case?
We don't know about many studies that have compared pre and post measurements. There are some studies, I think, performed in China and Morocco, but they are point estimates only during the pandemic. So this is quite rare to see that we have a pre and post estimate and can compare directly. So the only thing I know about is the US study that was performed by our collaborators in the US. So we have a very similar setup in the data collection.
And what kind of value do you think the pre and post would bring to countries which haven't done it, as opposed to doing just a point study?
The pre and post, I think, is important because you cannot say much with a point estimate if you can't put it in, because we know that the quality of life isn't starting at 1 before. So we need to know where is the baseline to know how we can compare the point estimate. So I think that's necessary if we want to make any conclusions about the change in quality of life.
We have another question in the chat, which is saying the depression is one of the main disadvantages to a stricter lockdown, and asking if the fact that Sweden did not have a strict lockdown have positive effects on mental health compared to countries that did.
Well, that is also a thing that we could look at. We have actually measured the existence of depression and anxiety using an instrument called the PHQ. And that has been done in both Norway and Sweden. And if I remember correctly, there weren't big differences between those countries. We have not been able to do any detailed analysis of that, so I can't say that much about it. But that's a very interesting question, and I think we would need to look into the details of the data to say anything more about it.
And in your research, did you find any particular aspect of EQ5D has been affected more or less?
So here we saw that the dimension that were affected was the anxiety and the depression dimension, and that is also to be expected, perhaps. So that is the driver of the EQ5D reduction. It is the change in anxiety and depression.
We don't have any more questions in the chat. So if any of the people watching do actually have anything they want to say, then now is the chance to do it. But we don't want to keep anyone longer than they need to be. So if everyone is happy and has no further questions, then I guess we can start to wrap up. That was a really interesting and very current talk. And I'm sure that this research, well, I hope that you get the funding to do the next stages for this so that we can see what the final results are and if we can learn anything about the Swedish approach from this kind of research. And I hope that people here who don't have the health economics background will see some of the relevance of doing this kind of research in the future. So thank you very much for joining us and for presenting that. And the report is available to read, as you said. So if anyone also wants to go into greater depth, then they can, I assume, access that from the Swedish Institute for Health Economics website. I would also say, if you've enjoyed this, then we have more ISPOR events coming up. So please do keep an eye on our Facebook and sign up for them and register for them as soon as you can. And also let us know if you have any ideas or if you have any comments on this event or past events or events that you want in the future, because we will do our best to cater to everyone's interests. So thank you very much to everyone who's joined, and thank you to Sara for sharing that with us.
Thank you.